Hi, my name is Connie Gilchrist and you're watching Third Cranial Nerve Palsy, Isolated Nerve Palsy. In this video, we will discuss the clinical characteristics of patients who have had a single muscle supplied by the third nerve palsied. The intention is not to go over all the clinical characteristics of each of the isolated nerve palsies. You actually have the skills to do this through all that you've learned in terms of the principles of incompetence strabismus and specifically in relation to the principles of neurogenic palsies. But I'll give you a brief overview of what to expect in isolated nerve palsies. In one of the previous videos, we talked about the fact that we could also have an isolated muscle palsy where the third nerve could be affected, but only for one extraocular muscle. So we could have an isolated superior rectus, medial rectus, inferior rectus, or inferior oblique palsy. Now, just bear in mind that it's uncommon to have an isolated third nerve palsy. It's more common to have either a complete third nerve palsy or an inferior or superior division palsy rather than only one nerve of the third nerve complex being affected. In any case, it's important that you are able to identify an isolated muscle palsy because they can occur even though they're not as common as the other types of third nerve palsies. So we'll go through each of these very briefly and we'll start off with the superior rectus. Okay, so with the superior rectus palsy or an isolated superior rectus palsy, we're usually seeing this as a congenital condition. And as expected, you would see a primary limitation of elevation in abduction. So if you have a look at the patient here in right gaze, we see that in abduction and elevation here, the left eye is the affected eye, and we can see that there's limited elevation of the superior rectus. We also see a hypodeviation in prime position as we have a elevator that is not functioning. In this particular instance, or in the patient that we see here, it's not very obvious that there may be a hypodeviation, but there does appear to be an XT. Okay, so the greatest deviation will be in lavo elevation for this particular patient just here. So we can see here a Hess chart of a patient with an isolated superior rectus palsy, and it's of the left eye. And again, we can see in the outer field here, the superior rectus underaction and just a mild one there in the inner field. And we can see the contralateral synergist overacting here in the outer field as well as in the inner field. A medial rectus palsy. This is very rare to have an isolated medial rectus. So you will need to think about differential diagnosis here if you see a patient with a medial rectus because it is uncommon. But clearly this would mean that if your medial rectus is not functioning, we'd have limited adduction, and this would mean an exotropia in primary position. So here we have a patient with a medial rectus paralysis. We can see an exotropia in primary position given that the lateral rectus is unopposed and is an abductor. When we take the patient over into left gaze, the lateral rectus seems okay here and the medial rectus seems relatively okay there. But as we move over into left gaze, we can see significant medial rectus underaction of about -4. And so here we have a right medial rectus palsy. So the deviation will be greatest in lateral gaze, and in this particular instance with the right medial rectus palsy, it's greatest in lavo version. This is a Hess chart of a patient with a medial rectus palsy, and it's a medial rectus palsy of the right eye. And what we can see here in the outer field is that the medial rectus is underacting. We can see this also in the inner field, it's underacting here. And the ipsilateral antagonist is also overacting in the lateral rectus of the right eye. We can also see that the contralateral synergist here is overacting, so the lateral rectus here of the inner field, and then also of the outer field, we can see it's gone off the scale here. The inferior rectus palsy. This is relatively uncommon, and when it presents, it may be congenital. The greatest deviation will be in depression in abduction. If we have a look at the patient to the right, here we have a patient with a left inferior rectus palsy, and we can see that the greatest deviation is here in lavo depression, consistent with where the inferior rectus or the left inferior rectus acts. And we can see we have a significant left on right in this position. In prime position, we're expecting a hyperdeviation and an exotropia, or possibly an exotropia. And we're expecting a hyperdeviation because the inferior rectus is a depressor, and so the eye will elevate. In the example we have here, we can see actually that we have a hypotropic eye rather than a hypertropic eye. And the reason is the patient is fixing with the hypertropic eye, the left eye, and because of this, we now have a right hypotropia on presentation. This is still a left inferior rectus palsy and has been diagnosed as having the patient has been diagnosed as having a left inferior rectus palsy. And we can see that this left on right is consistent with what we expect of a left inferior rectus palsy. The left eye is higher than the right. It is simply that the patient is fixing with the left eye in this example that we have a hypodeviation of the right eye. And here we have a Hess chart of a patient with a mild left inferior rectus palsy. And we can see here the underaction of the inferior rectus in the outer field. We can also see it in the inner field here as well. And we can see the contralateral synergist overacting here in the outer field and in the inner field here. And finally, the inferior oblique. Now this is very rare and again likely to be congenital when present. And here we will see limitation of elevation in adduction. So if we have a look at this patient here, as we take the patient into dextral elevation, we can clearly see that the left eye is not elevating and we have an inferior oblique paralysis or palsy. Given that you have an elevator that is affected, generally you'll see a hypodeviation in primary position and you may also see an esodeviation. In this particular example, it does not appear that we have anything obvious in primary position. And here we have an inferior oblique palsy of the right eye, and we can see here on the inner field we have an underaction of the inferior oblique, but we can also see it here on the outer field. Of the left eye, the outer field has only just commenced being plotted, but we can see on the inner field here an overaction of the superior rectus as well, the contralateral synergist. Now, before we conclude this video, we have to consider differential diagnosis when we're presented with a patient who appears to have an isolated third nerve palsy. Given that, as I mentioned a few times now, it's not common to see an isolated superior rectus, medial rectus, inferior oblique palsy, etc., we need to make sure that that is indeed what the patient has rather than any other conditions. So with a medial rectus palsy, where you see a medial rectus palsy, you need to consider the possibility of a Duane syndrome or an INO, which you've learnt in a previous subject. So with a Duane syndrome, we have a patient here to the right with a Duane syndrome, and this particular patient, when they're coming into adduction here to the right, has limited adduction. So a medial rectus minus in this particular instance. We'll talk more about the distinction between Duane syndrome and medial rectus when we come to Duane syndrome, but you already know that we'll be looking for lid changes and globe changes with regards to Duane syndrome. In relation to an inferior rectus palsy, we need to consider the possibilities of a mechanical restriction, so either a blowout fracture or a thyroid eye disease or myasthenia gravis could mimic what appears to be an inferior rectus palsy. In terms of an inferior oblique palsy, this can be mimicked by a Brown syndrome. So here to the right, we have a patient with a Brown syndrome. This patient is looking into dextral elevation, and we can see that the inferior oblique is underacting. In this particular patient, it's not an inferior oblique palsy that's occurred here. It is a Brown syndrome. There is a video on Brown syndrome, so you'll learn more about this particular condition and the differential diagnosis between Brown's and inferior oblique in that particular video. And finally, the superior rectus palsy, consider a mechanical restriction again, so think about blowout fractures and thyroid eye disease. So in summary, when you're considering what the clinical characteristics are of a patient with an isolated third nerve palsy, you need to just go back to your principles of incompetence, strabismus and neurogenic palsies, and you can determine what to expect in primary position, where the greatest deviation will be, what the expected abnormal head posture will be, etc. However, you also need to strongly consider your differential diagnosis if you have a patient who you think may have an isolated third nerve palsy. In terms of this differential diagnosis, it will become clearer how to distinguish between the nerve palsies or the isolated nerve palsy and the other conditions as we move into the next module. To the right here, we also have a table from Ansons and Davis, which lists the key characteristics of each of the isolated nerve palsies from the third nerve. Okay, that brings us to the conclusion of this video. Thank you for watching.